This podcast is sponsored by Pfizer. At Pfizer, we believe collaboration is essential for advancing the treatment of chronic immunoinflammatory diseases. Through research and education, we remain dedicated to supporting the healthcare community to improve the lives of those impacted by rheumatic diseases. To find out more about our commitment, visit Pfizer.com. And don't miss our Innovation Theater at ACR Convergence, presented by Dr. Christina Charles Showman on October 26th at 2 p.m.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. We have electronic health records full of notes and labs and billing codes. But try asking a simple question. For instance, how many of my rheumatoid arthritis patients on hydroxychloroquine have had an eye exam this year? And the answer vanishes into chaos because our health records weren't built for medicine. They were built for billing. And that's where today's story begins. My guest is Dr. Thomas Grader-Beck, a rheumatologist and clinical informatician at Johns Hopkins, and one of the leaders behind RheumCode, a new initiative from the American College of Rheumatology. It's an effort to create a common digital language for rheumatology, a way for our data to finally mean the same thing wherever it lives. Think of RheumCode as a shared vocabulary that allows every EHR, every clinic, every registry to actually talk to each other, to make sense of the stories we're already documenting. In today's episode, we talk about how RheumCode started, how it might change the way clinicians practice, how researchers study disease, and it might even change how patients experience their care. This episode is part of a special series of conversations airing during ACR Convergence 2025 in Chicago, where we're highlighting just a few of the novel ideas being discussed at this year's meeting. Dr. Thomas Grader-Beck is an associate professor of clinical medicine in the Division of Rheumatology at Johns Hopkins University School of Medicine, and he's the clinical director of the Program to Accelerate Clinical Research using EPIC. Board certified in internal medicine, rheumatology, and clinical informatics, his work bridges clinical medicine, autoimmune disease research, and electronic health record innovation. He's a member of the American College of Rheumatology's Registry and Health IT Committee and serves as the project lead for RheumCode. Enjoy. Thomas, welcome to the show.
Thank you for having me.
You know, I'm super excited to talk to you. You have quite a unique background, not only in rheumatology, but also informatics. And I'm wondering if you could describe for us how you became involved in informatics. What was that passion for you? And then with that background, how you became involved with ACR's RheumCode.
Yeah, well, thank you for asking, and thank you for raising these important points, because I think that clinical informatics up until this point hasn't really played a big role in rheumatology, and we're really hoping it's becoming more to the forefront. And so in my case, I started out, I was actually a translational bench researcher, and I was studying antibodies in the blood, and I was trying to correlate those findings with clinical characteristics. And as part of that, you go through records of patients. And I was thinking there's all these paper records. How am I ever going to make sense out of them? And of course came the revolution of EHR. And I was like, this is a really good opportunity to define patient populations on a new level and actually starting to shed light on subpopulations of the disease and so forth. And so informatics in the beginning really helped me to understand patients on a different level. And so I started to become what's called an Epic Physician Builder, where you can create tools in the EHR. And so I was heavily involved in Johns Hopkins to create new data collection tools that would help us to do better research and better understand our patients. And in that process, I realized that the EHRs are really not made for our purposes. So it really turns out that you probably know that in the beginning, EHRs were systems were built for administrative and billing purposes, and not really with the idea in mind of, supporting the patient, supporting the clinician, and so forth. And so when I started to look at the data that we actually have, after all the, efforts that clinicians put in when they see the patients and how little comes out of that, that's when I really started to think about, well, we need kind of a common language that really explains what we need, and how do we explain that also to EHR vendors, for example, right? And so that was one of the ideas of how RheumCode evolved. And in the beginning, I was reading about similar efforts in oncology, which was really on the forefront. And then we came up with the term of RheumCode, basically.
Very witty. So it sounds like, I guess the challenges you're describing is that the way that I describe a patient with rheumatoid arthritis in my clinic, I may write in on a text, right second MCP, swelling and tenderness, whereas somebody else, uses the homunculus to like note that, and somebody else has a different way of notifying that. And I guess the challenges with that is that if you're trying to look at, our patient population of rheumatoid arthritis patients, you can't compare one thing to the next because everybody's sort of describing their patients in a different way. And I guess your hope is if we all use the same language to describe patients, then maybe we'll be better able to compare and thus do research and advance our field of rheumatology. Is that what you're trying to get at?
Yeah, absolutely. That's from our perspective, absolutely. And, I think that you gave the example of rheumatoid arthritis. It doesn't necessarily mean everyone has to do exactly the same thing. But what we would say is we agree that certain things are really necessary to help us, right? And how we get to those things, there may be different ways, but the concept of how we define it would be the same.
So, talk a little bit more about RheumCode and sort of what the ACR plans to do with RheumCode and sort of how it started
How it
and where
works.
it's going. Yeah, how it
Yeah.
works. Great.
So I think that one thing to keep in mind, it's not like a solution that goes from the beginning to the end and we just, throwing it out and that's it and everyone's going to be happy. So it's going to be a process that actually is going to take quite some time. But in principle, what we want to achieve is that, and that originally came from the patient perspective, actually. Let's say you want to go into an EHR system and you want to learn about your medical history, your diseases, right? Like you go in, you may not find anything in the beginning, right? And then you put a filter on top and all of a sudden it becomes clear where things are and like how you can actually take that out. And in a sense, RheumCode is that system that would allow us to find a way into each EHR system and to the places where the information is that we want to know about, and then some instructions of how that information should look like. And so what we want to do with the ACR is that we want to develop what's called use cases. So meaning specific clinical scenarios where we want to have measure a certain outcome. Let's say, we can bring up, for example, safety of medications, right? So that would include, identifying patients that have a certain disease, first of all, then taking a certain medication, like what dose were they taking, how do we record that over time and so forth. So in the end, we can give a good statement on what taking that medication for a patient means. And I can say that to you, right? I can go to the EHR vendor and I can say, this is what we want to do, but we're not speaking data language, right? And they don't know really how to do this because they don't have those experts on their system to do it. So coming with a blueprint and saying, these are the concepts that we need in the EHR system, those are the ones we really want to focus on. And so with the ACR's help, we want to basically develop these cases over time so they can be immediately useful when they're implemented and they don't require like the whole system to be changed all at once.
So, not only sort of within a certain EHR, but also between EHRs so that there's some sort of interoperability so that, you can go to Epic or Cerner or any one of these things and sort of pull the information that you want because it's all being collected in a similar fashion.
Absolutely. And I mean, in the end, that is the real strength of RheumCode, which, the EHR systems we have been struggling with interoperability for quite some time. And that has, recently changed. And that's one of the reasons why RheumCode has a chance to be successful. And we can talk more about that. But yes, if we are able with this kind of blueprint to capture across EHR systems, then we can really make powerful statements about patient populations, because our diseases, of course, are rare, right? And so the strength is really in the numbers. And so the more sites are involved in figuring out how a treatment is doing or what the patient needs, the stronger the message is.
So where are you at this point in terms of the development of RheumCode? Are you at the point where you're trying to establish sort of those use cases before going to the EHR, or are you already working with the vendors to try to implement some of your
Mhm.
ideas?
No, we're not at all at the vendor stage. There are a few stages even before that. And
Okay.
I will admit that we're still at early stages. And one of the reasons is that we, need quite a lot of expertise that we're
Mm,
still trying to find to join our efforts. But in a nutshell, what I can tell you is that we have quite a good knowledge now on how to approach the RheumCode project from a technical standpoint.
mm,
So we know now, what avenue we would pursue for the formal technical development. There is something called Codex, which is a certain institution within a standardization governance structure called HL7 that is specifically made for this kind of project that oncology and cardiology have also used. And that's the forum in which something called an implementation guide will be developed. And these guides reflect the use case. So we spend a lot of time listening to other people and hearing about pitfalls and, what kind of margin around the use case we should have, not too complicated, but, powerful. And so we have a pretty good idea about that. Now, in order to move forward with pilot projects, we did some initial polling within our own group. What would be use cases that may be,
mm,
powerful to have? They would be simple, but maybe powerful to implement. And some that came up, is DMARD safety, which is, of course, very important. And it could focus even on just a specific medication like methotrexate or let's say hydroxychloroquine and eye screening, retinal toxicity screening,
mm,
for example, or osteoporosis, either more in general in terms of screening, but also being on certain medications that require, like denosumab, require periodic treatment. So those are initial use cases, but we're not necessarily, stuck with those. That will depend part on the funding that we can get for initial pilot projects. And we do also want to have more input from the rheumatology community. What is it really that, that would be valuable that
mm.
people see?
Who makes up this group that you're working with?
So the RheumCode group is in principle members from the RIT committee and also from the QMS committee.
Yeah.
So those two together, we have a fluctuating group of about 4 to 5 members at the moment, but there are only a couple of us who have really clinical informatics skills. So there are not many that, so for example, we don't have a fire expert, which we haven't
Mm.
talked about the technical part of fire, right? Like, but there are a lot of nuances that we need to cover. And so that's part of our finding effort still, like who can we identify to help us?
Amazing. And how does RheumCode differ or compare with the RISE registry, which is another like big ACR
Oh
effort?
yeah,
How are they similar or different?
no, actually, so RheumCode kind of feeds into the RISE registry. It lives by
Mm,
itself, but it feeds into the RISE registry. And the way you can imagine is that what happens at the moment in the RISE registry is that, let's say we have small practices and you see patients, you report on them. And so there are these the quality measures, right? And the RISE registry is very strong on providing support for clinical practices to meet their quality measures every year and when they do their reporting. And so when the practice participates, basically certain third party vendors that work with the registry have to go into the system and figure out how to actually determine those quality measures. And there are instructions for that, but each EHR maybe have different structures. And so the vendors are kind of needed to make sure the quality measures are captured correctly. And sometimes there are problems and they're not. And
Mm.
having RheumCode be a layer on top that is fire based again, and that's the future of also what the vendors are using to go into the EHR, will actually make it much easier for registries like RISE to get that information in the most accurate way back.
Got it. And just for listeners out there, fire, you're not saying about,
Not
this thing
fire.
that burns. I think it's called fast healthcare interoperability
Yes, it's a
resources, right?
mouthful.
So,
Yes, it's a mouthful. But if I can explain it on a very simple basis, think about, let's say you have a few credit cards, right? And you use them to buy something, right? But you can never get access to your credit card statement, right?
mm,
And so having something layered on top, like some online banking, right? Like where you can log into your account, you can go to different categories and you can find some of these, items that you purchased. That is kind of what Fire does. It gives
mm,
instructions of how to get into the system and get to the right place, and also what it means when you're at that place, how the number should look like. It should not be words, it should be like digits, for example, and decimals, right? Like, and things like that. And so, because FHIR is a regulatory requirement for EHR vendors to enable with their systems, that opens up the communication in between EHR systems. And
mm,
because each FHIR kind of location in the EHR has certain standards defined, like that should be used in that place, it makes it quite uniform across all the EHR vendors. So that's FHIR kind of in a nutshell, right? And then we're coming in with RheumCode and we say, well, this FHIR structure, and this FHIR structure combined, that's something that helps us for rheumatology. And that's something that we need to know. And sometimes there may not be an element there yet, and we need to actually add it to the catalog. So
mm.
that can happen.
Super interesting. I love that comparison of the credit cards with the
Imagine,
statements
yeah,
and,
as a patient, right?
fire.
Like you have all these cards and you just use them. You go to see different clinicians at different practices, and you never find out like what actually happens to you, right?
Yeah.
So, yeah.
Super interesting. So, how are you determining like what is essential data, like what clinical elements like you actually need to capture, and what things are optional? And also, like, do you want this to be like structured data or do you want it unstructured data? How are you thinking about those challenges?
Yeah. Well, I think, essential is always relative in a way because it really depends on the use case. And that partly depends on, for example, are you in an academic setting? Do you have other priorities than like in clinical practice, right? Like, and so I think there may be a minimum to explain a certain use case that everyone needs to have to make a statement. If you don't know by the patient taking a certain drug and for how long, and you don't have the right measures, you can't make any statements. But then there may be a wider circle, if you're also interested in clinical research, like the catalog could be a little bit more, right? So the essential really captures the elements that without that, you're not able to answer the question. And I think for each use case, this has to be decided in pilot projects with discussion with experts of the disease. That also includes not just academic rheumatologists, but also private practice and what is really relevant for the clinical care in private practice on an everyday level. And that will determine what the essential is, and then there could be a second ring around that, and so forth, right? And you could imagine that it can be quite a flexible system. Now, in terms of how to capture that data, that's where it comes into play that we have all these different EHRs, right? And they don't all necessarily have the same tools, and if clinicians are in a certain EHR and they document in a certain way, it's often because that's what's possible, right? And so we don't want to, and we can't also come in and say, well, now you need to change everything or you need to document everything, with click check boxes so far, right? So this is the beauty of the system too, because by creating a space where that data lives that we need, there are different ways to get to it, right? And so I think there is going to be quite a role of AI in the future
Mm.
in EHR systems to help us basically extract that information from things that already exist. And of course, there's a lot of work that needs to be done for that, meaning we have to, find the right prompts for the large language modules and so forth to look at the right things, and we need to know that we do it right. But that could be one option. But I do think, I mean, from my own work, if you do have systems where you can be part of the creation of tools, like in some systems that's possible, then like I'm, in Epic Physician Builder, like you can then create smart tools that make it very easy to capture that kind of data. And if that is all you need for sometimes for a patient visit, right, it can actually be very fast. And I think the most important part, and maybe that's something, is a good place to mention that here, is that let's say we say, okay, these are important things for the patient, right? Like we want to capture a certain number of data elements. This is very important that people in general agree that this is important. It's not that we are saying it's important, but we as a rheumatology community think it's important. And so then what happens is, if it's really important, it should help the clinician that uses the tool to better understand their patient. So we need to use these tools, if we collect discrete data also, to show what that means for the clinician. So for example, like dashboards that show them how their patients are doing based on the data they collect, identifying patients that have a care gap, where we say they're missing this because, we haven't seen them in forever, whatever it is. So it can't just be on the kind of data collection side, but we need to think it all the way through to how it helps the clinicians to do medicine better.
I think it's always challenging. Like, you're not demanding that physicians change the way that they document in order to satisfy sort of your requirements, but maybe by making it easier for them to document the things that are, shown to be like clinically important, for patient care, and making it easy for physicians to do it. Maybe that would be.
Yeah, absolutely. But also, I mean, think about the fact, like, if we have a blueprint and we really say something that, the ACR supports, right? And say, this is what we need to describe like a patient's, like one use case, then this is all you have to do perhaps for a patient that you see, for that problem, right? And so it can actually be very, very fast. At the moment, we're documenting so many things kind of to satisfy billing requirements. But if that structure changes and say, well, let's just focus on what we really need, right? Like that can actually, the system can be very helpful for defining that. And I think, I mean, we've seen some coming down on documentation requirements already. And I
Mhm.
mean, the other thing that I think will play in our hands is that we have more intelligent, transcriptions, and AI helping us even with transcriptions now and summarizing. So we need to get all of those things right. But I think that in a few years from now, we will see a big change in general how documentation in the EHR works. And we need to work on capturing the meaning behind that.
Super interesting. And I wonder, yeah, I mean, at this point, transcription is very passive, right? Like the AI just writes down what we say. But I wonder in some future, it'll nudge us and say, hey, did you ask about, ophthalmology evaluation in this patient that's been on hydroxychloroquine for 5 years and hasn't seen their doctor? Or, hey, don't forget to, check labs on this patient who takes methotrexate or something like that.
Yes. And, if it's in the right place at the right time and if it's justified, right, I think no one of us would be offended by it, right? Like, but
Yep.
that is something you definitely have to get right so that you don't say, well, did you think about that? Right. And you say, well, I already thought about that. Why don't you know that? Right. Like, so that is the challenge. And I think,
Yeah.
but I think that's where these data structures will really help us, to make that better.
Yeah. RheumCode, I think, has a lot of stakeholders,
Mhm.
right? And I wonder what, from a vendor perspective or a clinician perspective, what some of the barriers are for implementation. You mentioned, one of the things is trying to get funding. So
Mhm.
I wonder like how this project is, what do you need the funding for? And why would, Epic or any of the other EHRs want to work with you to try to incorporate these things into their platforms?
Yeah, I think this is a development project in that sense, right? So let's say we had a blueprint for a use case, and I would go to Epic and say, "Can you please put that in?" So, and they would
Right,
say, "Well, I'm not really interested in that. I have so many other projects, like, and like."
right.
So in the beginning, you have to raise interest, right? And so the way you can do that, and I am referring back to Epic for the moment, but it's a principle thing. So if you have any way of actively participating in a project, like, as for example, if you can create content and so forth, it becomes, of course, much easier. You can do pilot projects. You can say, I want to prove that if we have 10, 15 sites that all, use a certain tool to collect the same kind of data that we use, the room
Mm,
code structure for, and then you can show, there is a meaningful outcome from this, right? That raises
mm,
interest, and that also raises awareness for new projects that come down the line. When it becomes really interesting is that when it's so far developed that, well, the EHR vendor could say, well, I'm not interested, but you say, well, the ACR is behind this. We've shown this is important. And maybe we even have quality measures around it that we really need you to implement, right? So the pressure can rise, but also, I think it's in the interest of the EHR vendors because they want to make their product better. But of course, they try to get away with as little as they need to. But with
mm.
this, we can raise more high level pressure on it as well, right? So, but we don't have to do that. Certainly in the beginning, we have enough flexibility of doing some projects that doesn't require kind of that.
Yeah. As you mentioned, this is a long-term project, right?
Yes.
First, trying to figure out like what data you want to collect, what are the use cases, doing trials to see if it works, going to the vendors and telling them that this is the way we want to collect this data. And then I imagine, physicians may or may not need to be trained about how to do it. Do you think that physicians will need to do something differently, or is it already going to be incorporated in sort of the flow that we do
Yeah,
already?
I mean, the biggest lesson for me, over time has been that really the workflow is one of the most important things, right? Like when we are working in the EHR.
Yeah.
And so, whatever we would try and design new, it would be as minimal kind of interference with what is actually already happening, unless,
Okay.
nothing is happening and everyone just tries to make it happen somehow, right? There may be an overall better new solution, but in general, there should be as little impact. And again, it comes back to the fact what the gain also is for the clinician that works with that, right? If they just feel they would use it to collect data, that shouldn't be the goal. So it's really a long-term project. But I do want to bring up one other thing, if I may, which is, just also think about guidelines, for example, right? The guidelines
Mm,
that the ACR has on osteoporosis, on, disease activity, and whatever it is. Like, all these guidelines we really have developed on paper, right? Like, and they're still all on paper. But if you take the paper and you say, well, what does it mean if I take this and I look in the EHR systems, right? Like, how do I represent everything that's on paper in there? And how can I apply the guidelines to that, whatever is going on in the EHR system? And we find, right, we don't know. We haven't done that. And there are some other organizations that have done that, and CMS has started to do equality measures by describing exactly what you should pull out of the system, and that is also FHIR based, right? And so
mm,
if we ever want to get to a stage where we are, for example, ask, well, may the guideline help in this situation, right? Like, or this is another reason to use a kind of a system like this. And so in the end, it's really a way of rethinking our knowledge about rheumatology as well, and how we describe rheumatology, right? Like, with this whole digital revolution that has been going on.
super interesting. And I guess the benefit for clinicians of implementing something like this, in theory, would be, improved patient care,
Mhm.
right? Like easier adherence to guidelines, or, making it more automatic that you routinely get, labs for methotrexate or osteoporosis screening, or any one of these things. Let's say it's 5 years down the road and RheumCode is implemented in all major EHR vendors.
5 years.
Uh,
Okay.
no,
You
am
make
I
me
am I too
you make me
optimistic?
sweat. I I mean,
Okay.
that would
And
be
so,
nice. I think if in 5 years from now, we would have completed, like, let's say, 2, 3 pilot projects, yeah,
oh, okay.
I think I would be very happy about that. And just
Okay.
because I don't think it's a linear process. I think, it will accelerate and accelerate, but I think these beginning stages will be on the slower side. So, and when you say room code implement, like, we don't even know what room code is in the sense of the content, right? Like, we're developing the content as we go, and that
Mm,
makes it actually doable. Like, I can't bring you the whole dictionary like today for the future. Like, we're developing the dictionary based on the use case, right? But that's what makes it doable. So,
yeah. Okay. So 10 years down the road, like, what are the outcomes
yeah.
that you wish, to have from this project? I mean, it sounds like great. It sounds like it can improve patient care and sort of on the day to day, but sort of on the big picture, what do you envision this does for patients, for clinicians, for researchers, and for our community as a whole?
Yeah, yeah. So I think, if we go back to use case and maybe the different circles that we talked about too, like the essential circle, maybe the research circle and so forth. But imagine the data that is available on our patients can be really merged, like really in real time, basically, across, let's say, the United States, but it's really, I mean, the EHR systems are expanding beyond like the borders of a country also. But let's just say whatever the community is, it will give us so much more insight in all kinds of things, like, locally, what differences there may be in the disease, even things like access to healthcare, right? Like, all of
Mm,
those things will contribute to really paint a more granular picture of a disease population and how patients are doing, which then really in the end helps us to make better treatment decisions. Like, you can start to say, well, I have this patient here that I have never really seen before, right? But let's imagine for a moment everything goes to the RISE registry, right? Like, so, the RISE registry could answer questions like, well, but there are maybe 100 other patients that look like this, and this is what they have responded to. Then you could compare
mm,
that, right? And you could say, well, what are the chances this may work? And so it could give you some guidance for those patients, for example. It could be as simple as you said before, just reminding us sometimes we don't think of everything. And whenever we forget, like, this could really, be the key to do that. It could also help us to show that, some treatments are maybe more effective than others on the large scale data that we have, right? So kind of real world experience and what works in society and what not for treatment of the disease. So, and then you go into also clinical research. And of course, you could even expand that to academic sites or other sites that have biosamples, for example, right? Like, and you could think about what that would mean maybe for research and discovering new markers and all of those things. So, I mean, there are so many different opportunities, and it really depends on defining those circles and what they allow us to answer.
yeah. I mean, it's so interesting. Everything that you mentioned, like, on the one hand, it's so obvious if you had to create medical records from scratch, like, of course, you would want your medical records to automatically be able to, like, tell you about your patient and what's needed, and talk between, different records, and recommend, things based on other patients. Like, of course, you'd want that, but, you know, uh, they're so siloed, in this day and age that it's so hard to
Yeah,
get.
in the early stages, there was no focus on interoperability. And the other part was that, yes, there are data standards, but no one really felt obliged to use them. Like, there
Hmm.
was no requirement in any way. And so all those years, there was a lot of data, but it's really hard to understand it. And, we can't just go, like, everyone talks about big data, right? But, like, if you extract something like it's called ICD-10 codes. Most people are probably familiar with it. Just from the, EHR, like, ICD-10 for rheumatoid arthritis doesn't mean someone has rheumatoid arthritis, right?
Hmm.
It's used sometimes for other reasons. It may be an error.
Hmm.
It may be whatever it is. And every one of us who's worked with that kind of data knows that that's not good quality data.
Hmm.
But that wasn't the focus initially, right? It was just getting the digital revolution started in some way. So in hindsight, probably would have done it differently. So.
Yes. Not, as you mentioned, not as software for billing, but as it's software to care for patients and maybe research. I mean, it sounds like super interesting and like an awesome project. I'm wondering, what do you want, our listeners to be able to do if they want to help you in develop RheumCode and, making it live and making it real? What can, people that are listening to, how can they get involved?
Yeah, no, absolutely. We definitely need help. And, one front is certainly on the technical side. So if anyone is listening in who has clinical informatics experience, who has, fire knowledge, terminology knowledge, or knows people who have that knowledge and may be interested in collaborating to make this happen, definitely reach out. Also, we do like to hear from people about what are the most difficult things they're struggling with on a
Hmm.
high level and what they would like to, have resolved in their EHR systems. We do like, if the EHR vendors are listening, we'd like them to also contact us and start conversations. We will have a network event at the ACR. Yeah.
Amazing.
So, do feel free to also stop by. We'll have some time to answer questions and, engage your interest and see how we can help integrating your feedback into that. And of course, I mean, if there are lucky listeners that in any way have thoughts about philanthropy and funding or, have ideas about how that could also get off the ground. I mean, there are grant funding mechanisms. Of course, there's pharmaceutical industry that may also be interested. So there are some avenues, but we would definitely also exploring all options that we have.
Awesome. And Thomas, we'll put, some of those links on our website so that listeners can, learn more about RheumCode and have a way to get in touch and to find out about the networking events. Thomas, this has been a really interesting conversation. I really appreciate your time. Sounds like you have your work cut out for you. It certainly sounds very challenging, but certainly worthwhile. So, best of luck. And I'd love to have you on the show, to assess your progress in the future.
Yeah, thank you so much for having me and giving the opportunity to talk about it.
Take care.
You too. Thanks.
Right now, our EHRs record thousands of tiny fragments, joint counts, lab results, medication lists, but they don't add up to a coherent picture of a human being with a disease. RheumCode is a blueprint to change that, to turn digital documentation into clinical understanding. If you'd like to learn more, you should check out the RheumCode Networking Lounge on Sunday, October 26th at Convergence 2025 in Chicago. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. Show notes for this and all other episodes can be found at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep charting and innovating. And of course, stay healthy. Here at ACR On Air, we'd like to take a moment to thank Pfizer, the sponsor of this podcast episode. Their dedication to research and collaboration with the ACR and the field of rheumatology has been essential to improving the lives of those impacted by rheumatic diseases. To find out more, visit Pfizer.com.